a great title.
Thank you, Jenica. I think this is going to come on here. So yeah, thank you for the invitation. We're excited to tag team this grand rounds. We've titled it AMI Shock, New Tricks for an Old Dog, with the emphasis on old will become apparent, I think, here. I do have some disclosures for consulting with a balloon pump company, but otherwise we're mostly non-conflicted. It was fun, I think, for us to put this together. Dr. Pobbs, Dr. Sobs, and Teddy. But we'll try, hopefully we'll still be invited back to do this again. Just to set the mood, we're going to be focusing on age as it relates to medical care and some complex decision-making in these shock patients. But I think this gets us in the right frame of mind. So we're going to start with a AMI shock case, and then I'll kind of lead off talking about some of the data and the approach to temporary circulatory support for patients with AMI shock, and then we'll kind of turn it over to Marwa and then Pablo to go into considerations around VAD and transplant in that setting. So we'll jump right into our case, and we have a couple audience response questions along the way. So Dr. Spetko will lead the team in making sure we ring into those. 74-year-old man who really had minimal past medical history other than hyperlipidemia. He was on Zetia due to statin intolerance, and he presents with acute onset chest pain. He was a very active guy, married, lives in Boston, doesn't have any children, works as a graphic designer, was an avid horseback rider, very active guy. This is his initial admission EKG, sinus rhythm with atrial and ventricular ectopy, and there's some ST elevations in the early precordial leads, and then more prominently ST depressions in the lateral leads V4 through V6. This was felt to be concerning potentially for STEMI. His initial exam is notable for a really narrow systemic pulse pressure. He had slightly cool extremities. And his labs were notable for some acute kidney injury, mildly elevated liver transaminases, a mildly elevated lactate. And notably, his NT-proBNP was 3,500, but the first troponin was undetectable. This was his chest x-ray. He's got mild cardiomegaly and at least mild interstitial pulmonary edema. So he goes to the cath lab due to concern for STEMI, so urgently rolls to the cath lab. Hopefully these will start playing here in a second. And the cath findings were fairly tragic. Basically 3-vessel occlusion of all the major coronaries here. Moments ago. We're not. These were running. Yeah, we just ran this. Well, minor/crucial details here of the case. That's all right. Well, I will fast forward. The bottom line here is that there's complete occlusions of all 3 epicardial vessels. So the RCA was occluded in the mid segment. There was actually a bunch of collaterals from the sort of proximal RCA, right to right and right to left collaterals. And then the left circ and LAD are occluded proximally. And ultimately, Dr. Temez felt these were probably chronic total occlusions, and this gentleman had been living mostly off of collaterals. Notably in the lab, he's somewhat hypotensive with aortic pressures in the 70s and gets started on norepinephrine. So this is I think people are familiar with this, but we're been trying to push the clinical use of the SCAI shock stages. And I think this is permeating the CCU and other units, but our patient would fall into SCAI stage C as a patient with evidence of hypoperfusion also hypotension, requiring some initial pharmacologic, if not mechanical support. That's differentiated from sky stage D patients who are deteriorating despite that initial support, often already on a temporary MCS platform. And then sky stage E, who are really patients who are about to, quite moribund, about to have circulatory collapse, many of whom have already had cardiac arrest. So this brings us to our first audience response question. I'll come out to the poll here in a second. Don't use that QR code. Or maybe you could, but all right, so we'll present that. Let me make this bigger. But the question, so this is just to refresh, a 74-year-old guy, minimal comorbidities. He's sky stage C shock in the lab, 3 vessel occlusions of the epicardial vessels without any clear, at least percutaneous revascularization option. So what would you do at this point? Do we add an inotrope like dobutamine or epinephrine, place a balloon pump, place an Impella CP, or initiate VA ECMO? Those are our options. Should be able to scan this. Bringing in. This is kind of the spectrum I think I expected. So most people voting for Impella CP, some folks voting for balloon pumps. We'll come back to, those choices. So what evidence do we have for choosing between these support strategies in patients with AMI shock? There's a fair bit now of observational data, and now, thankfully, some randomized trial data to help guide us. Folks are probably familiar with this DanGer shock trial, which was published in the New England Journal of Medicine about a year and a half ago. And this was a trial of adults with STEMI cardiogenic shock. So they all had STEMI. It enrolled over a decade at centers in Denmark, Germany, and the UK. This was originally the Dane shock trial, but the Danes failed to get things over the finish line, so had to pull in the Germans and the Brits to get us there. But it is noteworthy that there was over 1,200 patients screened to get 350 patients into this trial over 10 years. Their shock criteria were systolic less than 100 or needing pressors, and you need to have a lactate over 2.5 or a low mixed venous. And importantly, they excluded patients with out-of-hospital cardiac arrest if they had poor mental status, with the idea to try to exclude patients that may have had significant anoxic injury due to arrest, where the circulatory support wouldn't really drive their outcome. You can see the characteristics here. This was a older, predominantly male population, predominantly AMI shock. Systolic pressure mean at randomization was in the low 80s. The average ejection fraction was 25%. Only 20% of them notably had arrest prior to support. And the mean lactate was 4.5. The majority of these patients were sky stage C, with 44% being stage D and E. These are the results from the primary outcome. The primary outcome for this trial was 6-month all-cause mortality, actually, on the left. And then the key secondary outcome was a composite cardiac outcome of need for transplant, escalation of MCS support, or death. You can see that compared to, in blue, the standard care patients, those who received the microaxial flow pump or Impella had lower hazard for the primary outcome as well as the secondary cardiac outcome, with a hazard ratio around 0.74, and that was statistically significant. And this was exciting in the field as like the first randomized trial showing the benefit of a temporary support platform in cardiogenic shock. But not to be taken without a grain of salt, in the sense that we were certainly in danger in terms of adverse events with Impella. And these are some of the major adverse events that were tracked in the trial. And you can see that the rates of major bleeding, limb ischemia, and the need for renal replacement therapy were substantially higher in the Impella cohort, with more than doubling the rates of those adverse events, particularly with limb ischemia and renal replacement therapy. There was also a higher rate of sepsis and bacteremia. So certainly a significant potential downsides with the use of Impella support that we need to factor in. No. Danger shock? No, just Impella. Yeah. AMI shock, STEMI shock randomized to Impella versus standard of care. This was like a little bit deeper dive on the acute kidney injury outcomes. It was published in Circulation subsequent to the initial paper. And you can see that rates of AKI were substantially higher in the Impella cohort, and then the need for renal replacement therapy. And interestingly, these were the factors when they looked at risk factors for kidney injury amongst the Impella group. Having suction events, running a higher performance level, and having longer duration of support were strongly associated with kidney injury. I think factors that lead us to question whether some burden of hemolysis is part of what drives the higher rates of kidney injury in the patients supported with Impella. What about the real world? Dr. Garan is always trying to get us into the real world with the shock working group. This was just published a couple of months ago by Tony Carnicelli, looking at what's the experience with Impella CP support. And you can see there was about 860 patients with AMI shock who received Impella CP. The inpatient mortality for those patients is still about 50%. But I want to highlight the rates of adverse events. Again, substantial rates of these adverse events. These absolute rates are similar, if not higher, than in the Danger Shock trial. So if we're going to use this therapy successfully, we've got to choose patients where the circulatory compromise is severe enough that the benefit of the device is going to outweigh adverse events. How do we choose that? Well, I think one helpful parameter may be the initial blood pressure and sort of vasopressor support. This is a nice analysis that just came out in JAMA Cardiology, looking at the association of the initial systolic blood pressure in these patients with mortality. On the left-hand panel, you can see that as the lower the systolic blood pressure at randomization, the higher the odds of mortality. And then I'll highlight this right-hand panel, which sort of the sweet spot or where the greatest delta or reduction in mortality comes for patients with Impella support in orange versus standard care in blue, comes with hypotension, with systolics in the low 80s or below at the time of randomization. So that may be a useful clinical tool to sort of triage the use of Impella for AMI shock patients at the time of presentation in the lab or when you're seeing them in the ICU. What about ECMO? We're doing, as people know, a fair bit of ECMO here now. These are our annual rates at BI. Where just last fiscal year, we did over 80 cases of ECMO. The preponderance of that is VA ECMO, about a third of which is for patients with some flavor of AMI shock. What data do we have for using ECMO for AMI shock? This is the ECLS shock trial that also came out in the New England Journal in 2024. This was a randomized study of over 400 patients in Germany and Slovenia who had AMI shock. You didn't have to have STEMI in this trial. Slightly stricter shock inclusion criteria. So systolic had to be below 90 on pressors, lactate over 3, and one other metric of poor perfusion. And the primary outcome here was 30-day mortality, which is a more typical outcome in shock trials. And you can see the results of that here in the right-hand panel. There was ultimately no difference in 30-day mortality between patients with standard care in blue versus VA ECMO in red. Perhaps some separation of curves a little bit in the early days, but ultimately no difference at 30 days. I'll highlight two things. One, the control arm, of over a quarter of them had temporary MCS. Actually, 12% of them ended up getting VA ECMO. And this was really isolated ECMO support. So only 6% of patients in the ECMO arm had some mechanical unloading strategy. So this was really VA ECMO without a concomitant balloon pump or Impella. The patients in ECL pretty sick. They were arguably sicker than in the danger shock trial. You can see more than 3/4 of them had arrest prior to support. The mean lactate was now 7, and over 1/3 of them were sky stage E. So those are our sickest sort of in extremis patients. I think that's appropriate, though, for a VA ECMO trial where we know the morbidity of the therapy itself is quite high. And certainly we saw that in terms of adverse events. There were some similar themes to danger shock with the Impella in terms of rates of major bleeding and limb ischemia being more than doubled in the ECMO group. I'll highlight, though, that the rate of renal replacement therapy was totally opposite signal. If anything, the rates of needing renal replacement were lower in the ECMO cohort. Again, I think adding some additional sort of indirect evidence that the use of Impella support is higher risk of renal injury. One criticism of this study was that it was VA ECMO without concomitant unloading, and is concomitant unloading particularly important after the insult of AMI shock? There's a lot of observational data. On the left-hand panel is a large European multi-center registry of ECMELA in blue, that's ECMO plus Impella, as they like to call it, ECMELA, versus VA ECMO in red. And patients managed with concomitant Impella had lower mortality. We found similar results in an analysis of the ELSO registry of comparing VA ECMO patients versus those who had a concomitant balloon pump or Impella. The observational data has been pretty consistent. We don't have randomized data about concomitant unloading yet, but the observational data have been pretty consistent with lower mortality. But again, there's this penalty of adverse events, bleeding, probably more limb ischemia, definitely more renal failure and hemolysis. That's been pretty consistent. So we need to be thoughtful when deploying a strategy like ECPella. All right, so this brings us to our second audience response here. We can navigate it. Oh no, hold on. Come back to this in 1 second. So our patient gets balloon pump, even though you guys voted for Impella. Roger said, no, we're going to do the balloon. I mean, not unreasonable. We'll see. These probably aren't going to play either, which is amazing. Funny that they would. So there's tragic LV dysfunction. It's probably better that they don't play. The thing that I'll highlight is that the ventricle is pretty dilated. The 6.2 centimeter left ventricle, severe LV systolic dysfunction. EF was 20%. We get at least a still shot of the MR there. There was a lot of MR, 3+ functional MR. And so I think this was a little bit surprising in the sense of this was highlighting some chronicity here, probably, in terms of a ventricle that's really remodeled and dilated with a lot of functional MR. I can click through there. So despite us not maybe going with the optimal, or at least what the audience wanted to go with, he actually settles out on balloon pump. We wean off norepinephrine, urine output improves, lactate normalizes. We finally get a swan in, didn't do a swan in the lab. Why would we do that? But he's actually doing okay in the unit. And now we're kind of, how do we reconcile this? Because we've been told, you know, balloon pump doesn't work for AMI shock, right? IBP shock 2 trial failure. The Europeans have banned this device, essentially. We can't use the balloon pump. But this patient probably was more complicated. We probably got a little bit lucky in a sense that he probably had a previously unrecognized ischemic cardiomyopathy. And we know that in patients with heart failure shock, this device can be potentially pretty effective. This is some data that Rashad led when he was at Columbia, looking at in these panels on the left are the change in cardiac output and the change in mean PA pressures within the first 24 hours after initiating balloon pump support. This is in over 200 patients who had acute on chronic heart failure shock. I like this figure because it shows the variability in balloon pump response. So you've got each of these lines is a patient. So you have some patients that are kind of super responders. They increase cardiac output by a couple liters, drop their mean PA pressures by 20 points. And then you have other patients that have no change in cardiac output and no relief of their congestive state. When they looked at factors that were associated with sort of failing to respond to the balloon, the things they saw, and this has been shown in some other studies as well, ischemic cardiomyopathy, smaller ventricles, lower PA pressures, less MR, and sort of low SVR were factors that portended a poor response or lack of response to balloon pumping. So I like to think of balloon pump response as sort of three pillars of favorable balloon response. Number one is you want a patient with LV dominant failure. How do we define that? Combination of hemodynamics and echo, low RA to wedge ratios, relatively preserved PAPI, right ventricle that looks pretty good on echo. We'd like to see some metric of reversible congestion, left heart congestion. That would be elevated wedge, elevated PA pressures, and particularly significant mitral regurgitation, where counterpulsation is often quite helpful in getting us better forward cardiac output. And then finally, elements that would define cardiac output reserve with afterload reduction. So that's usually dilated cardiomyopathy patients, bigger ventricles that are more afterload sensitive, a history of chronic heart failure, and then more preserved SVR. So our patient actually had a bunch of these things. He was sort of a dilated cardiomyopathy patient. He had significant MR, relatively preserved SVR, and hemodynamics that would suggest decent RV function. So he actually settles out. Now we're coming to our second audience response. This a little bit bigger. So he's day 3 in the CCU, right? We've got the balloon pump in through the leg. Shock state has settled out. We've got options for next steps. I'll mention because I, did not give you the coronaries or the echo. The coronary targets were not great. Surgeons are looking at it. The echo showed, relatively preserved wall thickness, but not in the inferior wall. So we could do cabbage with balloon pumping. We could do cabbage with Impella 5.5 support. We could do a 5.5 and start meds. We love meds, GDMT for recovery, or maybe we'll place a VAD or do a heart transplant. Or throw in the towel. It's always an option. We shouldn't refer to palliative care. Palliative care is important. But this guy was very robust coming in. So okay, we've got a lot of splay here. I like it. So we got votes. The leader in the clubhouse currently cabbage with a 5.5. We've got some recovery people. I like my recovery. That's Spetko, probably. He's an optimist. That and transplant, some ringing in. Awesome. Yeah, I think this is where the meat is. This is not an easy decision. And we're going to lean on Dr. Sabe and Dr. Quintero to help us with that. So I'll leave you with 2 last slides. First is this concept of Impella-assisted cabbage or valve replacement. This is an emerging approach. We've done just under 10 cases. I was checking with Masashi yesterday here. There's not any randomized data in this space yet. They're mostly smaller case series. This is a series from Germany of patients that got Impella-assisted cabbage. This is for low EF patients versus propensity match folks that had the usual cardiopulmonary bypass. And you can see, at least in their hands in this small series, better survival, more freedom from major adverse cardiac events with Impella Assist. So this is becoming a strategy that we can think about to avoid sort of hemodynamic collapse and end organ compromise for high-risk patients that need to go to the OR for revascularization or valve surgery. So I'll leave you with the beginnings of this algorithm. It's hard to make algorithms for these complex decisions, but I think stratifying patients by the initial SCAI stage is useful. For SCAI stage C patients with AMI shock, we're probably leaning towards the Impella, with the exception of patients if there's a background of chronic heart failure. I think we can think about balloon pumping. We're probably not going to deploy ECMO in SCAI stage C. And then for D and E, it's a little more complicated. For D, we're probably leaning towards Impella, CP or 5.5. If there's BIV failure or respiratory failure, thinking about ECMO. And then for our stage E patients, that's really where probably using Impella CP is going to be inadequate. So we're thinking about ECMO, maybe with concomitant unloading. And that opens up kind of the next phase. Like after we support them, we've got to look at whether they were able to get revascularized successfully. And then there's complex decision-making around this 5.5 assisted CABG or maybe advanced therapies. So with that, I'm going to turn it over to Dr. Sabe to guide us on that next phase.
So much. I think I'm going to stand right here, actually. Thank you, Will. Always a hard act to follow. But just the question is, are we going to use an LVAD in this patient? And just like a quick reminder of what LVADs we have available, there's only one FDA-approved LVAD available at this time, which is the HeartMate 3. And you can see that this is the newest technology, fully magnetically levitated impeller, wide passages to reduce shear stress. It's frictionless, no mechanical bearing. So, the technology now is that these patients have very low pump thrombus. We can actually go without aspirin, and we can run their INRs quite low, especially in patients who are GI bleeding, which is great. And just so that people are aware, there is a VAD being studied currently, the Brio VAD, which is very similar to the HeartMate 3, but is kind of a little bit more convenient for patients. It's more flexible, comfortable driveline, smaller devices for the patients to hold on to. But just so you know that may be coming soon. And as the technology has improved, so have the outcomes. And you can see, as you can see all the way on the left here, and I think this pointer works, our original first generation pulsatile devices, which had, longevity about 2 years, now moving forward to our HeartMate 3. And you can see with those advances, we see that the outcomes have really improved significantly. But what about LVADs in AMI shock? So the first use of this was a really nice little article here in the New England Journal of Medicine back in 1986. The first time that a patient was received a surgical LVAD was one of the pneumatic, you can see the size here, but the pneumatic device, which was surgically implanted and pumped blood. It removed blood from the left ventricle and pumped it into the descending aorta as opposed to ascending aorta, which is what we do now with our newer devices. And this patient was successfully bridged to transplant for a whole 2 days, and then they received their transplant. But that was the first report of that. And subsequently, there were multiple other small case series and reports of patients who presented with acute MI who were bridged successfully to transplant with LVADs. In more contemporary data, but still a decade ago, there was a nice Intermax analysis that looked at patients who received an LVAD, who received it because they had AMI and non-AMI reasons, and found that patients with AMI, there was no difference basically between the two groups, despite the AMI patients being more critically ill at the time of implantation. And what you can see here is at 1 year, and again, this is about a decade ago, but at 1 year, the patients alive on device were 52%. But if you look at this is basically looking at competing outcomes, 25% of the patients were transplanted, 20% did not survive. And then a small percentage, I'm just going to mention this because I'm going to talk about this a little bit more, but 1.6% actually recovered and were able to be explanted. And then on the right here, you can see that this really does depend on age a little bit. So older patients tend to have lower survival and lower transplant rates. And not surprisingly, patients who present with AMI shock and non-AMI shock to LVAD centers tend to have better outcomes. And that's especially in patients who are under the age of 75, who are more likely to get to advanced therapies. And that's really probably driven by the fact that LVAD centers have a robust shock program, have, a temp MCS devices. You can see in red here, these are the LVAD centers compared to the non-LVAD centers, and just a higher use of temp MCS in these patients, or in these centers. So what are the pros and cons for LVAD therapy in general and in this patient in particular? Well, we always think of transplant as the gold standard, which it still is, but we have to remember that there's not organs available for all patients. There's immunosuppression that's associated, et cetera, and LVADs are available right on the shelf. And so something to keep in mind is that actually in the early years, patients actually have similar outcomes, can have similar outcomes in VAD and transplant. So here, this is an analysis, a recent analysis that looked at a single center, but looked, they propensity matched patients who received an LVAD versus patients who received transplant, and found that the 3-year survival was very similar in those patients. And this is the same even across age groups. But it does come with a price. Patients who receive an LVAD are more likely to be readmitted in those 3 years for both cardiac and non-cardiac reasons. So patients with LVADs tend to have bleeding, infections, et cetera. And then this is soon to be published data from Nir Uriel's group that actually compared patients from the Momentum trial, which is a trial that looked at HeartMate 3 and the UNOS registry, and really focused on patients under the age of 50, and found that when they propensity matched these two groups, they found that the survival was very similar and high, actually at 2 years, 91% in the young population. So more to come on that with the younger patients. But besides survival, what about other metrics that are important to patients, like quality of life and functional capacity? This Intermax analysis from a few years ago actually looked at patients who received an LVAD to see what happens with their 6-minute walk distance and their quality of life. And you can see that it's really significantly improved across all age groups. That's even in the patients who are over the age of 75 compared to a younger population. And the patients who are older actually may have less complications than the younger patients. Another important point to consider is recovery. I mentioned this a little bit earlier, but especially in patients who have, a new diagnosis of heart failure, haven't had a chance to see meds yet. This patient is presenting with, acute MI, albeit has a little bit of a dilated ventricle and maybe had some chronicity here. But there are patients out there in the registries, about 1 to 2% of patients actually do recover. But if you use a bridge to recovery strategy, you can see up to 11% of patients can actually recover. And so there is this protocol out there that was looked at in the Restage trial. It was a small study of HeartMate 2 patients, but really looked to see if the LVADs themselves actually can lead to reverse remodeling. And then you add to them GDMT and a robust GDMT protocol with echo optimization and right heart cath optimization, you actually could get some of these metrics here at the bottom to in terms of hemodynamics and LV size, and actually recover these patients. The ICARS score that's based on the Intermax data wanted also to show us how can we predict which patients are more likely to recover than others. And it tends to be the younger population, age under 50, patients who've had, like I said, shorter time with their diagnosis of heart failure, maybe haven't had the chance to see meds yet, ventricles that are smaller, less than 6.5 centimeters, non-ischemics, and normal kidney function. So, but speaking of size, so even if this ventricles, smaller may help us to get to recovery, too small can be problematic as well. So ventricles, and we talk about this a lot, especially in the patients who are presenting with acute MI, who have really not had any heart failure to start with, they have not yet dilated. And so an LVAD may not be the right therapy for these patients. Patients with an LV dimension less than 5.5 centimeters actually tend to have much worse outcomes, and that the curves you can see separate very early on here. If you look at the patients that are more likely to have small ventricles, they tend to be older, more often female, smaller BSA, which is not surprising, and tend to be the ischemics, as I mentioned. And what happens with these patients is not only do they have worse outcomes at 2 years in terms of survival, but we can't run their speed very high, and they tend to come in for more readmissions for low low flow alarms, basically. And then, as you can see, you know, the septum, it's already not, you know, this is a non-dilated ventricle, and then the septum is being pulled more away from the right ventricle. And so they tend to have early and right heart failure as well, which is associated with worse long-term outcomes. Another, and so, you know, another disadvantage here is that patients who are older, LVADs tend to be a final destination therapy. And so in the past, we used to use VADs as a bridge to transplant. But after the 2018 UNOS allocation changes in terms of listing for transplant, patients with LVADs have moved from, they used to be 1B and often 1A, honestly, if they just had a simple driveline infection, were waiting at home, and now have been moved down to a status 4. So with the better technologies and patients are living longer, doing well, they've also had, you know, sort of a disadvantage in terms of getting to transplant. And so you can see a significant decrease in the patients who are listed with LVAD and become listed after LVAD. And so they're waiting a lot longer, like I said. And what you can, you know, this annual report from Intermax in 2022, which is our national registry of patients with LVADs, you can see that, so I'm just going to point out these because I know there are a lot of lines here, but the patients who are alive on device, which is in green, there's a lot more alive on device, but there's a lot less, which is the dotted blue line, who get transplanted in the new era compared to the old era before the allocation changes. And then in those patients that you do want to consider maybe bridging to transplant, this is a little bit controversial because there's more data coming out on this, but these are some data from UNOS that showed that patients who get to transplant from LVAD may actually have worse post-transplant outcomes. If you think about the path to transplant now, since the UNOS allocation changes in 2018, in order for a patient to actually get to status 2 or 3, they tend to have not a simple driveline infection like in the past waiting at home, but they need to be hospitalized for a very severe infection, severe GI bleed, et cetera. So they're a lot sicker patients going in. And you can see on the right here, it just shows that the patients that are in the new era with complication actually have much worse survival than the patients in the pre-2018 era with or without complications. And then in the end, age still matters. So, you know, even though we saw that patients who are older still have an improvement in quality of life and functional capacity and survival, and you can see at 5 years, about 50% of patients over the age of 70 actually survive, which is pretty decent. The patients who are younger still have better survival. So at 5 years, 73% in the patients who are less than the age of 50. And so this is brought around this idea of prolongation of life. So if you think about patients who are much younger, maybe in their 30s, 40s, you know, how long is a transplant going to last for them? Median survival 12 to 14 years, and may need retransplantation. So there's this idea of, well, why don't we give them, you know, 10 years on a 8 to 10 years on a VAD, and then they get their transplant after that, so have a total prolongation. But that's really in the younger patients. Other considerations for LVAD implantation is that patients who are not listable now or ever for transplant, such as those with pulmonary hypertension, recent cancer diagnosis, other reasons they can't be on immunosuppression. Morbidly obese patients, our cutoff here is BMI greater than 40. Other centers are 35 as their cutoff. And then I bring up age here too, because, you know, even if we're going to think about transplanting somebody who's in their 70s, are we going to transplant a patient who is 80, for instance? But we would consider an LVAD patient like that. Patient preference also comes into play, especially these patients who are waiting a status 2 in the hospital. Some of them don't want to wait in the hospital for weeks on end if it's going to take that long, and they may want to go home. There's also some new changes in the UNOS criteria that came into play in September, that you actually have to try inotropes before going on to temp MCS. And so some of these patients who may go home with an inotrope as a status 4 may prefer and therefore can't drive, whereas patients with LVADs can drive may prefer that, or they may prefer that they go to an LVAD. So that may increase the number there. So how do we decide in the end, you know, which way we go with all of this? As many of the fellows in the room know, we'd have these multidisciplinary VAD and transplant selection meetings. Many of you presented at these meetings on Monday afternoons, where we actually talk about all of these different parameters. And one of the parameters that we discuss is the HeartMate 3 risk score with every patient that we present. And this is, you know, a risk score based on some of the parameters I talked about earlier, including age, prior stenotomy. I did not mention before, but that goes into play here. Kidney function, parameters of right heart failure, which is right atrial pressure to wedge, greater than 0.6, and then LV dimension, so the small LV, and then this very, very easy to remember calculation here. And then you can come up with whether the patient is in one of these tertiles, average survival, higher than average survival, or lower than average survival. Again, very easy to remember these numbers, but you just have to kind of look them up. And our patient, lo and behold, had exactly average survival. So something to think about as we think about the next steps. One last slide here before I have Pablo come up is that just wanted to show you our VAD program, which first VAD was implanted in 2013. We've had 79 LVADs implanted since that time, 50 of which were HeartMate 3s. You can see that our population is mostly older population, although there are some younger patients who either in the early stages were bridged to transplant or could not be listed for transplant. And we've had 21 patients implanted at age 70 or more. One patient was actually implanted at the age of 80 and has lived on his VAD, I think, 5 years now, 4 or 5 years, which is great. And you can really see that our trends are similar to the national trends, which is that, nationally, since the 2018 allocation changes, LVAD implantation has just decreased in general. But you can also see we've moved towards red here, which is destination therapy. And so we've moved away from the, bridge to transplant and more towards, making a decision of, is this going to be the destination for this patient or a transplant because of the wait times on LVAD. Our outcomes are very similar to the national outcomes and excellent here. And then, one other point that I want to just make is that there are some new changes coming along too. Just thinking about our patients with LVADs as we think about, a resource utilization with transplant, et cetera, and these patients waiting a long time on VAD. And so now we're giving, there's going to be patients who have had a VAD for a longer period of time are going to now be allowed to be moved into a higher status for transplant because they've been waiting for that long. And now I'm going to pass the baton to
Oh, hi, how are you?
this patient.
Not too bad.
All right, it's gonna be tough to follow these two guys. So let me take.
So I had called.
So should we really move forward with the heart transplant in this patient? We all know that the elderly population is growing rapidly. We see it in our clinics, in our intensive care units. All the baby boomers are switching into turning 65. And when you think about 2030, there will be about 70 million people with that age. So we will encounter this patient population very often in the years moving forward. You guys may have seen this graph before, that transplants in the United States have been going up over the last few years. Here depicted in green, you see the trend really increasing as opposed to in Europe where it's been quite flat. Now, if you look into more detail from the SRTR registry, and this is a more updated numbers, July 2025, we are basically hitting about 4,600 transplants per year. One of the reasons why we're able to do that is that now we are using this type of donors after circulatory death, as part of the organ thoracic pool. So if you look in blue here, compared to donors after brain death, that has been a significantly increase, and now it's becoming almost 30% of those patients who get transplanted. Now, Marwa already alluded to this change in the allocation system in 2018. In 2019 and before, many of our patients who were transplanted were supported by mechanical devices, including durable LVADs, as shown here. So right after the next year, there was a significant jump into the temp MCS support, depicted in blue. It went from the 10 to 11% support, people going for transplant with temp MCS, to almost 30%. And if you look at last year, it's almost 40% on temp MCS. The other trend is ECMO utilization prior to heart transplantation. You see it in red, it's been going up, helping Dr. Grandin's program here. And the LVAD, we've been definitely, as the national trends, have been coming down as a bridge to transplantation. Now, you may want to ask, okay, what is the survival of a patient who goes through a transplant? In general, it's about 12 to 14 years if you survive your first year of conditional survival. Here depicted by ages, for those above 60, their survival, as you can see, is a little bit lower compared to the younger counterparts. And That's not unusual, right? Because even if you didn't have a transplant, maybe your survival is going to be better if you're younger. Now, if you look at recipient age as a continuous factor for 1-year mortality, looking at the ISHLT registry, certainly age matters. And the inflection point about that recipient is around age 60 or so. As it goes up, you'll see the hazard ratio going up, and our patient will be around this area compared to a younger counterpart. So these were my two main questions on this case. Is there really a role for urgent heart transplantation straight after an acute MI? And two, look, this guy is in his 70s. Do you really want to move forward? Do they do well if you are in your 70s? So we're going to try to address that. The main reason to put this slide here is to make Dr. Sabe happy, since it comes from Cleveland Clinic data. Very old data. This is 1992 to 1998, even before the shock trial, when we knew that after an acute MI, primary revascularization is going to be good for cardiogenic shock, but that was before that. So in this data, which is a retrospective analysis from Cleveland Clinic, some of those patients were into the conservative route. Everyone got a balloon pump, and some of them were thrombolized. The aggressive group had a revascularization here, or ECMO, LVAD, and transplant. And when you look at the inpatient hospital mortality, certainly it was lower in the people who just went straight to ECMO, LVAD, and transplant. Interestingly, the 5-year survival was also better, but they have a large price to pay here. Survival at 12 months in that cohort, about 60 to 65 post-transplant. If I tell you that that was our survival, they will shut us down. So that is a bad survival. But anyway, people were thinking, is that a pathway for patients just go straight into transplant? Now, heart transplantation, why would it be better? Well, I do feel that there is a better survival post-heart transplantation compared to other options for this patient. Better functional capacity. The heart adapts when you walk around. The LVAD might not. Better quality of life, and really no batteries if we're talking about LVADs. Unlimited showers, you might take it. And you can go swimming, of course. Now, if you want to go that route, wait for a heart, it doesn't come without a price. Really, if you go the way to transplant, you need to be waiting for the heart. And after transplant, the road is not easy either. You have a tons of pill burden. There is a risk of chronic immunosuppression, like infections, malignancy, kidney disease. And if you are on a VAD, you are on a chronic anticoagulation and bleeding and stroke. So that is a problem. Now, again, going back to our case, he's 74, he's in the 70s. Do they do well? These are some of the considerations that we think about with a patient who is in his 70s or he's an older adult. So certainly those patients have greater comorbidities. They have higher hypertension, higher prior malignancy history, higher CKD. As Marwa alluded, a lot of our patients are going the route of temporary MCS before transplant. Can this 70-year-old stay in the hospital waiting for transplant attached to a device? Is he going to get very deconditioned? How can we really assess biological age? Not every 70-year-old is the same, and many of them have all these risk factors that drive premature vascular aging that actually drives biological age. What is their cognitive function at this time, the psychosocial support? What does the patient really want to do? Goals of care at this time, does he really want to go through all this or not? We pay a lot of attention to frailty, and we work very closely with our physical therapy team and geriatrics, trying to objectively assess that. Our physical team usually calculates the short physical performance battery, and they can give you an objective number. They look at the balance, gait speed, chair stand test in the unit while people are waiting, sort of to try to give us information whether heart transplant is the right option for this patient. The geriatrics team uses this other modified frailty phenotype, and they've been very instrumental on giving us an idea. They participate in our multidisciplinary meeting. Both of these teams are attending our Monday meetings to try to discuss this issue. Now, age is also important from the donor perspective. And what have we learned from those patients who have actually been transplanted above age 70s? Well, it turns out that they are getting older donors. They are getting donors with more comorbidities, more diabetes and hypertension, And they are getting donors with a longer ischemic time, meaning the time when you get the organ out and you put it into the recipient. When you look at a continuous risk factor for 1 year mortality in the ISHLT database, donor age does matter as well. So really getting older donors, it might not be in the best benefit. Now, the next two data, we will look at the heart transplant outcomes in the UNOS database, which is the United Network for Organ Sharing, the most recent modern era. How do they do? So if you look at these two groups of patients, those above 70 and less than 70, there were only 1,100 patients roughly in this period of time that were transplanted above age 70. Those patients who were older had more malignancy history. They have a prior ischemic etiology for the cardiomyopathy. Compared to the younger patients are transplanted from higher UNOS statuses, meaning that they are sicker, likely, more use of ECMO in that patient population. And with that, their 1 year survival is actually statistically significant different, 89.2 for the older cohort and younger's 91.2. Now, if you go survive your first year, the 5 year survival is similar without not being a statistically significant difference, which is actually good. We were talking about a survival 5 years or 77.7%. If you look at the LVAD momentum trial, all comers, 55% roughly 5 year survival. So I think there is a survival advantage here. The other thing that we learned is that what is the driver of mortality in this patient population? Infection, malignancy. That matters because we should be thinking about adjusting immunosuppression for these patients in a different way than our younger cohorts. They are at more risk of infection, for example. And the other contemporary data from the SRTR data, which is the Scientific Registry for Transplant Recipients, if you look at the curve survival, 5 years, comparing the cohort above 70 in green and the 60 to 69, they look the same. There was no statistically significant difference there. What else did we learn? Well, the younger population have a better survival, infection-free survival, and malignancy survival. I'm not surprised about that. The rejection is actually very similar in between all the groups. In some data suggests that they have less rejection with that concept of immunosenescence as you age. And the other important point here is that the 60 to 69 and 70, they really did not have any difference in rehospitalization, rejection, infection survival. There is no controversy for any of us that anyone between 60 and 69 would be a potential transplant candidate. So this is the data that drives sort of what we're doing now. Now, the other big question is, can they wait? Because one thing is, can you get them to transplant, but can they wait before they get the transplant? And this is probably the only paper published in 2021 from the SRTR data asking that question. Are you able to wait and don't die while in the waiting list? And I just want to point it to this graph here. When you look at the days from listing death and not getting transplanted, the curves are very similar for the elderly population. So even though they actually don't die in the transplant list, they are able to wait. There were some risk, rate of delisting that was a little bit higher on this elder population, but the death was not different. So going back for our case, I think I wanted to convince you that it was complicated, the pathway for this guy. We admitted him September of 2023. We went through the algorithm that Dr. Grandin alluded, and he got a balloon pump. And then we needed sometimes to figure out what to do. He got an Impella 5.5. There were no options for revascularization, and we felt that he could be a suitable candidate. He was listed at day 7 as a status 2 in the CCU and transplanted at day 12, extubated the same day. Day 25 from admission, he was discharged home with services. He was 74. We had a couple of admissions with infections that we were able to deal with. His biopsies have been good. No donor-specific antibodies so far. His coronary angiography at year 1 has been good. And we actually switched him to rapamycin because of calcineurin-induced kidney dysfunction. This is not him, but I'm sure he actually enjoys the riding horse. He really loved that. In fact, we were concerned about this fungal infection because he was dealing with all the hay. But anyway, This would not have been possible if we hadn't launched the transplant program back in 2023 in August. This is a picture from that first heart transplant that nothing is playing here, but anyway, he's still alive, doing well. And I just wanted to show you our own data in the SRTR registry that is publicly available. If you look at our demographics, in the year of 2024 here, MAVI is our program. This is depicted by different ages. Our yellow age cohort here above 70 is actually larger than compared to our region 1 and our US transplant data. This is done on purpose. We didn't set up a transplant age contraindication in our program. We really want to look each patient individually, trying to decide whether your biological age is the same as your chronological age or not. Fortunately, patients have been doing well in all the markers in the registry. This is publicly available. We have really a very good survival on the waiting list compared to every transplant setting in the US, getting a transplant faster, and our 1-year survival is about 100%. So I think I want to leave you here with the complicated pathway. We went through, it's all spare here. You may want to take a picture and review it tonight. But this is what we did with this patient. He didn't have a good targets. We evaluated him for advanced heart failure therapies and decided that the best pathway for him could have been a transplant. So we have some time for questions.
Amazing, amazing. Time for a couple questions.
That wasn't just a good presentation. That was really outstanding. As I was trying to think about this patient, kind of trying to swim out of the Quintero, Grandin, Sabe, Bermuda Triangle, you know, you mentioned the targets, but you didn't get into the viability in this guy as well. Because, you know, sometimes the surgeons will say, oh, you know, no, those targets are okay. They'll plump up, you know, and where did viability fit into this, or how are you thinking about that in this patient and then more generally? I realize sometimes you don't have time, but when you do.
We anticipated this question from Dr. Gersten, actually. No, it's a great question, Rob. I know you and I have talked about this a little bit. At the end of the day, this case, I think, revolved around a feeling that targets were very poor. And we sort of had one shot to take with a 74-year-old. But to your point, or to the question of viability, that's fair. And I think, you know, that's sort of, you know, do you do impella-assisted CABG? They don't wean, and then we come back to this would be another way to go. And I think that's how we would have gone if he had been not the greatest candidate for advanced therapies. How do you assess viability in this setting is tricky. Obviously, MRI we can't do because of the support. And that's probably, I mean, we could lean on our imaging colleagues, but that's probably the quote unquote gold standard. The things that we think of doing, besides looking at the EKG and echo for wall thickness and R waves, is nuclear scan, just a plain SPECT to look, or PET. The PET requires this travel to the East Campus business. But I think either of those give you a good enough sense of LV viability. And I think those probably need to be deployed in somebody where you're thinking about high-risk revascularization.
You know, there's, you know, a lot of centers out there thinking of this idea of, you know, 3 parameters to look at LV function. What does the pump look like? What does the viability look like? And what are the targets? And if you have 2 out of 3 of those being poor, it's hard to move towards, you know, revascularization in those patients, especially surgical. That being said, as Will mentioned, you know, some of our younger patients, especially, I mean, there's one in particular that also didn't have, you know, has insurance issues, et cetera, so couldn't move towards advanced therapies. We did go forward with CABG despite having some of those parameters not so great. And now is a patient who's not doing well post CABG as well. So I think these are things that we're thinking about. But yes, absolutely. I think we have sent patients over to East Campus for PET scans on Impella so that we can make this, especially if it's like really tough to decide. I think in this patient, he was, had poor targets per the surgeon. Surgeons felt very poor targets and reduced ejection fraction, and some, probably underlying cardiomyopathy to start with. So not just, acute only.
Thank you. I was curious about the evidence. Danger shock took 10 years to do, but has been transformative in the field. Is there a greater willingness to enroll people in randomized trials of MCS, or how do we get there so that we actually have randomized data rather than relying on these registries?
Yeah, it's a great question. Obviously, it's like doing these trials is incredibly difficult. And there's been a few, as I'm sure you know, Kazi, that have failed and have been closed because of slow enrollment. And so people, really were congratulated, the ECLS shock and danger, just for getting them done. The logistics are incredibly difficult, right? Because you're trying to randomize at the time that someone's presenting severely ill. You have to potentially bypass patient consent. So there's a lot of those considerations. That being said, I think the appetite for doing these has increased now with these couple of trials that have been completed and have been done. And there's actually several ongoing where, I think we're going to get more randomized data in this space. But some of this, and, I think some of the critiques of these trials have been, we know that these strategies can help patients, right? Meaning we know if patients are in extremis and we put them on ECMO, we can get patients to survive. So we're really, we don't want to sort of over respond, I think, to trial data. It's important, I think, to randomize people in, at these different sky stages. And that's been a big advancement to sort of say, to funnel patients into trials in a more logical way. But my sense is the appetite for doing these has increased quite a bit. And networks that have emerged, like Shock Working Group, there's now these sort of networks of people, investigators that are interested in this space where enrollment can happen more efficiently across a bigger number of centers.